So pharmacology and medication administration. So as this becomes a little bit more involved as you move up through the ranks, but at the EMT basic level, you do have the ability to give out some drugs. So we have to go through and talk just a little bit about kind of what we look for in in medicines and the information that you need to know about the drugs that you're going to give, and then how to safely administer them, document them, those kind of things. Okay. It's a fairly short chapter, all right, but it's one that you definitely need to have an understanding of, all right? If you're going to take a medicine, a drug, something that's going to alter the way somebody's body works and put it in their body, you damn well better know what you're doing, right? You need to know what it's going to do to the body, what you hope to achieve by giving them that medicine, what can go wrong, what we expect to go wrong, right? There's certain side effects that we expect to happen because of the mechanism of the medicine. A headache with nitroglycerin is one. We call it a side effect because it's not what we were wanting it to happen, but it's something that happens in about 95% of the people we give nitroglycerin to, right? So we expect it, all right? If you don't know what to expect, you're not going to know what's good, bad, or indifferent, and if things are going poorly, you won't be able to identify them, okay? So taking it very, very seriously when you put something into somebody's body that's going to alter them, all right? There at the EMT basic level, like I said, it's a small amount of drugs and ones that are pretty easy and simple and straightforward, all right? I don't want to call them benign because you can actually do things, do damage with them, but fairly benign when it comes to the medicines, all right? You make the jump next door to EMT and paramedic, right? And that box gets huge. There's like 30 some odd drugs you're going to have to know, and some ones that do some pretty serious alterations of what's going on in your body's systems, all right? Things that can stay in your system for days at a time once you give it, right? And once you give it, you can't really give it back, okay? So make sure that we're taking this one fairly seriously, even though it is a fairly short chapter. I think we both covered most of that, okay? All of our medications are given under medical direction, okay? We have two types of orders. What are they?
Online and offline.
Online and offline, right? So some of them we have to get on the phone, some of them we give offline. We can just give them once we have, patient presentation criteria met, those kind of things, okay? But either way, everything we do is under medical direction, all right? For the most part, under the national curriculum, right, or the book, while you guys are in here, you're to assume that everything you give is online. You got to call a doctor and get orders for it. When you get to your system, local protocol can change that, okay? So, but while you're here in class, all your medications are going to be online, meaning you got to call a doc and say, here's what I got, here's why I want to give it, and get permission, okay? So, a drug or a medication is a chemical that is used to treat or prevent a disease or condition. So that's our definition of a drug or a medicine, all right? I believe that one's going to come up again at some point in time, so let's make sure we get that definition in our heads, okay? So the study of those drugs then is what's called pharmacology, where we get the title for the chapter, okay? And we break that down into various other things, pharmacokinetics and all the different kind of little subcategories of pharmacology, but the big heading is pharmacology, all right? So the medications we give have a very specific effect on the body, okay? When administered correctly, they can definitely improve a patient's condition very significantly, right? You'll see some big changes, even with the ones we give you at the basic level. Epinephrine, right, can make a big difference. Albuterol can make a pretty big difference. Nitro can make a big difference. All right, so you can actually make a pretty good improvement in the condition. When administered inappropriately, they can have some very serious side effects, all right, that can actually cause your patient to have some very detrimental outcomes, all right, which is why you need to understand the actual drugs themselves. So, EMTs, you only administer or assist drugs that are listed within your protocols, all right, with medical direction approval. All right, so you can't go and if somebody's like, oh, my sugar's high, I just need to take my insulin. Will you give it to me? Right? Insulin, I'm going to tell you right now, I haven't gone through them yet. Insulin is not in your approved list of medications that you can give. So even if, regardless of the fact that it is prescribed to the patient, you cannot administer that drug. And I would caution you on letting people self-administer their own drugs in your presence, because at that point in time, you're in charge of that patient and you're responsible for anything that goes in them. All right, so be very, very careful with those situations. All right, but if you're not approved to give it, you ain't give it. Yes, sir.
What do you do if that happens? You just document against life?
I would strongly, try and dissuade your patient from doing it. Just be like, hey, I understand it's your medicine, but while we're here, we've got separate rules we got to work off of. We're going to the hospital. You can talk with the doctor and the nurse there. Bring it with you, whatever you got to do. If they absolutely refuse, right, I'm not going to jump on top of them and restrain them from taking it, right? In the end, it's their medicine, so probably not going to hurt them. And so then absolutely document your attempts to keep them from doing it, and the fact that they refused and did it anyway. So, yes, sir.
Is insulin within the paramedics?
No, not even a paramedic. No. So not even a paramedic level for insulin. I kind of wish it was, but man, there's so many different types of insulins, and it takes a new onset. I mean, diabetics in here too. Every once in a while we catch one. So it takes a new onset diabetic a pretty decent amount of time usually to really dial in the right types, doses, all that kind of stuff. It's a little bit of a fickle thing. And then raising levels, changing levels of insulin too fast can be a problem too. So oftentimes they'll get put on drips, and it's very tightly controlled at the emergency department. So, us in the back of the ambulance going, yeah, that looks like about right.
And how do you manage your DKA patients then? With fluids?
Fluids and take them to the hospital. Yeah. So. All right. So here are some, we're going to go through the different medications that you as EMT basics are allowed to administer, okay? And there's two different categories. There's ones that you actually carry with you on the ambulance, all right? So they're stocked on your truck, in your bags, those kind of things. You can carry them, you can give them with medical direction, okay? There's going to be a second list. It's going to be medications that according to national curriculum, you can't carry, but if the patient has it prescribed to them, you can assist them in taking it, okay? So these are the ones that are carried on your ambulance. You've got protocol for them. Get your medical direction, give them, okay? Top left corner, starting out with oxygen. Okay, we're all pretty familiar with oxygen by now, hopefully. All right. Yes, it is classified as a drug. Okay, so it's on the list. All right. Top right corner is oral glucose. All right, used to treat diabetics who have a low blood sugar. All right, we're just basically giving them this nice little. It comes in different forms. This particular one is a gel. You just stick it in their mouth, and it's just straight sugar gel, right? It makes you pucker. It's so sweet. Those that have had it, sometimes it's hard to give them to them a second time because it's so sweet, it's nasty. All right, if you ever thought that was possible, right? And if you got a sweet tooth, you like sweets, you're like, there's no way possible. It's possible, right? You almost come back around to the other side of nasty sweetness. Bottom left is activated charcoal, okay? Used to bind the toxic substances when people overdose on stuff, right? So it gets down into the stomach along with the substance, it binds to it, doesn't allow our body to absorb it, all right? And then we end up sending it through the digestive tract and out the other end, right? Okay. This has kind of gone by the wayside, a little bit antiquated. There aren't too many places that I know of that are still carrying activated charcoal in protocol. I'm kind of okay with that because one, it's a complete pain in the butt to get people to drink. It makes a horrific mess. It tastes nasty. They almost always vomit. It's just a pain, right? It was probably more hassle than it was worth, which is why it's kind of going away, thankfully. And then bottom right is aspirin. Okay, aspirin's got a lot of different uses in the pharmacology world. For you guys, we're using it for cardiac causes, right? We're strictly doing cardiac, like chest pain, that kind of thing. We'll talk about it a little bit more as we go. All right. So oxygen, medical gas is indicated when we suspect hypoxia or hypoxemia. All right, the patient complains of dyspnea or is in respiratory distress, and the patient has signs of shock or poor perfusion. And the SpO2 is less than
94%.
100th time we've had that in the slide, and this hasn't changed, right? So basically what we're doing is anytime that our patient is showing signs of not having enough oxygen, we're just going to just basically straight up shove more in them. Okay, we're going to make the air that they breathe at a higher level of oxygen concentration, so that we have a higher level of success in hopefully getting them the oxygen they need. Okay. Talked about that. So oral glucose. All right. Brain cells require an uninterrupted supply of glucose. Can the brain store or process its own glucose, or does it have to come in the bloodstream? Has to come. Good. So we got to have a ready amount of glucose in our bloodstream. If we don't, and it drops low for whatever reason, oral glucose, we're just going to give it to them, absorb it in, and we're just going to artificially create an increase in the sugar that's circulating in their bloodstream. All right. Oral glucose may be administered to diabetics with low blood glucose levels. Okay. Where do you think? So people with low blood glucose levels, what do they start to have fairly quickly? Confusion, altered mental status, right? So if we start to get altered mental status as it starts to progress, we're not going to have the ability to do what? Talk to them. What are they not going to have the ability to do?
History,
Communicate, right? And then yes, no. The one I'm looking for is follow commands and swallow. Okay, so we're not going to shove, liquid gel up in their mouth if they can't swallow it, because then what are they going to do? They're going to choke on it, gag, vomit, create an airway obstruction, something like that.
Even a little bit under their tongue.
If they can't swallow, they don't get it. Call for ALS. We got other ways. All right. So we got to be careful with oral glucose. All right. So they got low blood glucose levels. Great. That's what it's for. It works really, really well. It's a little slower than the IV stuff we use as paramedics, but it'll get there eventually. We just got to make sure that we're administering it safely and that they can actually swallow it and protect their airway while we're giving it. Activated charcoal. All right. Activated charcoal is a fine black powder. It is exactly as its name would suggest. It is a medical grade charcoal, right? You throw the Kingsford in your grill, you light it up, right? It's a carbon. That's exactly what we have, although we've pulverized it to a fine powder. We've sterilized it, right? We've made it medical grade so we can actually put it in your body. I wouldn't recommend shoving Kingsford down your throat, right? So this may be administered in some cases of ingested poisoning, okay, to absorb the poison and prevent its, to adsorb the poison to prevent its adsorption, okay? So activated charcoal is what we call an adsorbent, AD, all right? It binds to the substance to prevent its absorption, AB, into the bloodstream, all right? So basically it just kind of locks up that whatever poison is in us, and it just flows through the system and never gets updated. Yes, ma'am?
So that only works if they took something orally.
Yes, ma'am. Yep. Orally ingested. So aspirin, all right, this is administered to patients with chest discomfort or pain related to a lack of oxygen supply to the heart. So like I said, aspirin's got a lot of uses for it, right? We can use it for pain, we can use it for fever control, right? It's got a lot of different things. The one we are most concerned about with in our setting, and this goes for EMT and paramedic as well, all right, is its ability to keep platelets from sticking together and prevent clots from getting worse when we're talking about coronary blockages, right, in the coronary arteries. So, what's that?
For stroke.
Nope. Nope. We let stroke be. Too much going on up there. Yeah. So like we said, patients with chest discomfort that we believe is going to be cardiac in nature, right? If I punch you in the chest, right, traumatic chest pain, not what we're looking for. We're looking for chest pain that we put together with the signs and symptoms that we think is related to something cardiac, all right? We'll have the chapter on cardiology coming up, and you'll get all those signs and symptoms, and it'll make sense once we get there, okay? Again, keeps the platelets from sticking together and prevents a complete blockage of the artery, all right? And therefore, hopefully, not going to improve our blood flow to the heart, but it's going to keep it from getting worse, all right? We'll talk about the one we're going to use to improve the blood flow here in a couple of slides. So, in addition to the ones that we carry on the ambulance, all right, we may also give or assist with giving some medications that are not carried by us, but that are prescribed to the patient, so the patient has them available at their house, okay? One of those is going to be an inhaled bronchodilator, right, or a beta-2 agonist, the most common of which is albuterol, all right? There are a couple other forms of albuterol. There's like an artificial one called Zopanex. If few different things, but albuterol is the one we're looking for, okay? It comes in two different ways. Typically, it's supplied at home by either the metered dose inhaler, right? The little puffer, everybody's seen those, yeah? Everybody's got that one asthmatic friend who's got asthma. Anybody? No diabetics and no asthma? Oh, we got one. All right. So we got the little puffer here. In some of the more severe chronic cases, oftentimes we'll also do what we call the small volume nebulizer, which is pictured up here to the left. Okay, we take the little bullet of liquid, we stick it in the machine, it makes a mist, we inhale it. Okay, we'll talk about that a little bit more because that's actually one of the skills you'll be doing here. Probably next week we'll get those started. All right. So, inhaled bronchodilators are prescribed to patients with chronic respiratory disease, okay? Asthma is one of the most common, but we also have our COPD patients, emphysema, chronic bronchitis, those kind of things, all right? It's, let me see here, I lost my spot on the slide. Given by meter dose inhaler or small volume nebulizer, we talked about that, all right? We may only administer medications that are beta-2 agonists designed to dilate the bronchioles. So what we're doing is we're taking that smooth muscle that lines the bronchioles and keeps determines the constriction and dilation of those, right? As to how big the airway is, all right? When we get reactions and things to asthma or to chronic conditions, that tends to constrict down. So the beta-2 agonist is going to allow that smooth muscle to relax, open up the airway, and we get more airflow in and out. Therefore, we get increased oxygenation, decreased respiratory distress, et cetera, okay? The drugs include albuterol and levoalbuterol, all right, or levoalbuterol, however you want to say it, right? The trade name on this one is Zopanex, so you may have heard that one used before. The next one is going to be nitroglycerin, okay? So pictured up here in the top left, all right? And then epinephrine, okay? Nitroglycerin comes in spray form or pill form, most likely in the pre-hospital setting. There's also drips, paste, those kind of things. So it comes in a lot of different varieties. But for the stuff that's prescribed and sent home to patients that you'll see, it's either going to be the spray, but most commonly the little tiny vial of tabs. Like that vial is only about like that big, all right? And the tabs, there's probably about 30 or 40 tabs in that little tiny vial. That's how small those little tabs are, all right?
Other guys, they have like a little necklace.
Yeah.
Just things in there.
Yeah, or the key right in their pocket or something like that. It's a lot of fun to try and shake one pill out while you're using gloves and bounce it in the back of an ambulance and then keep track of it and get it into the patient's mouth. That's why we've got the spray. I really like the spray. Epinephrine comes in an auto injector, okay? So this is actually, you will actually be giving an intramuscular injection when using the auto injector. You push it up against the skin, you push down, spring-loaded mechanism, it fires and delivers the medicine, all right? So real easy to use. So nitroglycerin, this is used by cardiac patients, okay? We talked about how aspirin allows the platelets to not stick together so we don't form clots and the clots that are there don't get worse, okay? So we kind of stem the flow of clotting, right, which is going to restrict our blood flow. And now nitro, we're going to use with our cardiac patients as well, because what it does is it dilates the blood vessels, okay, which decreases the workload on the heart. So now the heart's not having to work as hard. And we're going to increase the blood flow to the heart, which is going to give it the more oxygen that it needs that it wasn't getting when we had the blockage in the artery, okay? Again, we'll talk more about it in depth when we talk in the cardiology chapter. Obviously, if we dilate blood vessels, what can happen? We can start to get some drop in blood pressure, some hypotension, okay? Varies by patient, all right? Some patients respond very, very well, very heavily to nitroglycerin, some not so much, okay? So when we talk about giving nitroglycerin, we'll cover, your blood pressure parameters, your time spacing, all that kind of stuff, so that you can monitor and make sure you're not bottoming somebody's pressure out. Some people, you just give them to them one time and boom, there it goes, and you're like, all right, we're done. But some people, will just kind of have a slow decline. You almost always see some sort of a little bit of a drop in blood pressure. It may not be drastic, but there will be something there. Nitroglycerin must not be given to patients who have taken drugs for erectile dysfunction. Okay, so when we talk about the skill, it's one of the things on the skill sheet. It's a critical fail. It's an absolute must to both male and female. Okay, erectile dysfunction drugs work on a blood flow type basis, right? Increased blood flow equals increased fun, sensation, all the things we like. Okay. does the same thing in females as it does in males. It increases blood flow, sensation, fun, etc. Okay, so just because you're dealing with a female patient doesn't mean you don't get to ask about sexually enhancing drugs. All right.
People with pulmonary hypertension take it.
Yeah, we'll definitely get to that too, right? Because there's some sneaky ones out there. When we talk about erectile dysfunction, I like to say sexually enhancing drugs because that covers both the male and the female population a little bit better, as opposed to trying to ask a female about erectile dysfunction drugs. Right? Not exactly. Right? Doesn't exactly instill confidence in your knowledge of human anatomy, right? I always word it as sexually enhancing drugs. Okay. And we have to go back to about 24 to 72 hours, okay? Viagra was one of the first drugs to hit the market. It's fast acting, it doesn't last a super long time. You pop it just before you're ready and you can go throughout the night and then it's out of your bloodstream, right? Then we had Cialis, right? When it first came out, it was like the weekender, right? That's how they kind of advertised it, take it on Friday and you're good to go all weekend. So now we've got to stretch that time out because it's got that extended release. Now they've even got Cialis for daily use, right? You just take a little bit every day and you keep that therapeutic level and you're ready to go anytime, right? It's out there, all right? And it's out there. You'll be surprised, right? You'll get the answer yes more than you think you would, right? Still not like an every patient kind of thing, but it's there. Funny story about erectile dysfunction drugs. You want to know one of the cities that had the highest level when Viagra first came out, right? Its first year on the market, the highest level of new reported sexually transmitted diseases in the country. It was the Sun City community in Arizona, right? Because everybody that couldn't now can, right? It's the same developer, right? It's Del Webb. It's the same thing. It's just it's a lot bigger than the one in Georgetown. It's like about 40,000, I think, 50,000. The one in Arizona. And that was it, right? So everybody hadn't been doing anything for a really long time. Nobody got tested, right? Now everybody that couldn't can, and they all and it spread like wildfire. Newly reported cases of STDs, 55 and over community, the first year Viagra was on the market. There's a mental image for you for the rest of the day. Emma pointed out, right, that one of the important things about erectile dysfunction drugs is when they went to develop, they kind of found erectile dysfunction drugs a little bit by accident, okay? The drugs were originally intended for treatment of pulmonary hypertension, right, which is a high blood pressure that's specific to just the vessels in the lungs, okay, as opposed to regular hypertension, which is just everywhere in the body, right? It's a whole systemic thing. Pulmonary hypertension, it's got a long list of causes. Some people just have it. There's no real cause, right? So they were trying to develop this drug to treat pulmonary hypertension. Well, it did pretty good doing pulmonary hypertension, but it did really good making people happy, right? And so they went, I bet you there's more money in the happy side than in the pulmonary hypertension side. So they started marketing it down that route. Well, being the greedy pharmacology people that they are, right? Pharmaceutical companies, right? If you don't know about pharmaceutical companies, don't go research it, you only get mad. They kept going with the pulmonary hypertension route, right? But they couldn't call it Viagra because that's what they're selling to make people happy. I'm not taking Viagra. I don't have a problem with that, right? I'm not going to take that for my pulmonary hypertension. So they marketed the pulmonary hypertension side of it under the generic names so that people don't identify the two, but it's the same drug, okay? So keep that in the back of your head, be able to kind of recognize some of the generics of the erectile dysfunctions. It's like I know FIL is the last part. I think there's like sildenafil, tindalafil is one of them, right? There's a couple of different ones. I'll look them all up for you and I'll write them on board later for you. But the fills at the end are kind of suspect. So some questioning of your patient for pulmonary hypertension as well. They're supposed to be counseled not only by their doctor but by their pharmacist about the fact that yes, this is indeed also this drug, all right? And so if you have chest pain and somebody wants to give you nitroglycerin, you have to say, no, I can't have it, and this is why. But we all know that the communication between doctor and pharmacy and doctor and patient doesn't always happen the way it's supposed to, right? So keep that in the back of your head. So before you give nitroglycerin, any sexually enhancing drugs, how long? 24 to 48. 72 hours. Book says 48. Let's go to 72 and be safe to see how this goes all weekend. All right. Sound good? All right. All right. And the reason we do that is because we're dealing with blood flow. So the combination of the two drugs creates a massive vasodilation and a very severe hypotension that we can't reverse very easily. So by the time we can get it reversed or do anything about it, you're mostly dead today. Okay, and actually be fatal. That's why in the commercial it says do not take Viagra if you take nitrates for chest pain as a combination, may cause a, yeah, just like commercial. You may die. All right, so epinephrine, all right, this is used to treat, this is another one that has kind of like aspirin, it's got multiple uses in the medical field, especially in the pre-hospital setting. But the one that you guys are most concerned with as EMT basics, all right, is going to be the treatment of severe allergic reactions, also known as anaphylaxis, okay? When we get anaphylactic shock, we get massive vasodilation, we get swelling, all those kind of things. And so what we do is we reverse the vasodilation, the bronchoconstriction, and the permeability through the actions of the sympathetic nervous system. We all remember epinephrine from talking about the sympathetic nervous system, right? Epi and norepi. This is the same stuff, it's just synthetic, and we're just going to give your body an extra boost of it by injecting it in, okay? Patients with severe allergies may carry an epi auto-injector. They are out there. There's a lot of people that carry auto-injectors because of allergies. They're becoming a lot more common, a little bit more affordable. I say a little bit. And so doctors are starting to prescribe them a little bit sooner, right? They're not waiting for that person to have a severe allergic reaction. If they've got any sort of even a moderate level reaction, they'll throw in an EpiPen because oftentimes those reactions tend to get worse the more times you're exposed to it. So if you suspect anaphylaxis, you can ask your patient if they have an epi auto-injector and you can administer it if they do. Yes, ma'am?
Do higher levels like ALS and like paramedics, do they give it for like low blood pressure?
We don't necessarily give it specifically for low blood pressure, but we use it in things like cardiac arrest. We can use it in asthma. We've got a bunch of different things that we can use it for as opposed to just the anaphylaxis, right? I've got other drugs for and fluids and things like that for the low blood pressure. I actually have the norepi for blood pressure. We'll just lock you down and make your vessels the size of toothpicks, and then everything gets blood. Pretty awesome stuff. Works good. Don't leave them dead, right? All right, so when we look at the names of medications, so like we talked about albuterol and we talked about nitroglycerin, things like that, all right? Drugs have the different names, okay? So each drug will have one of these names that go along with it, okay? So the chemical name, all right, is going to be something along the lines of like this 1, 2, 3 propanotriol and the trinitrate, right? That's the chemist. If you were the chemistry major and you wanted to know how to make the drug or what it was composed of, all right, this is the name you're going to look at. It tells you a little bit about it, okay? We don't use chemical name hardly at all, but you need to know that it does have one, okay? The generic name, right, then would be something like nitroglycerin or something more familiar to you. Let's talk about ibuprofen, right? Okay, so ibuprofen is a generic name, all right? And if we skip over official name because it's usually very similar to the generic name, all right, but just know there is an official name. To the trade name, okay, if we're talking about the generic ibuprofen, what are some of our trade names? Advil, Motrin, right? So if you think about it, think generic is the store brand, right? The Walmart brand or the Walgreens brand or whatever it is, okay? That's the generic, all right? Whereas the trade name is something more along the lines of the Advils, the Motrins, that type of thing, all right? Nowadays, generics are becoming a lot more popular, all right, because they're cheaper to make. When you pay for a trade name drug, you're paying for the name, the advertising, the branding, that kind of thing. That's why Walmart Advil, right, or Walmart ibuprofen is like half the price of Advil, but works just as good because you don't have to pay for the advertising, the branding, the packaging, and all that kind of stuff that goes along with Advil.
Let's not forget the candy coating now.
Candy coating.
That's how they're selling.
Absolutely. So we've got chemical name, generic name, official name, and trade name. Okay, so generic and trade are the things you're going to want to be most familiar with when you're dealing with not only the drugs you carry, but then some drugs in general as you start to kind of learn some of the prescription drugs that your patients will be on as you get out into the field and see them. So we have different routes of medication. The route is how the medication is given to or taken by the patient. How do we get the drug into the patient? All right, that's our route of administration. All right, the route also affects how fast the medication starts to work. All right, if we've got to send a pill all the way down your digestive tract, it's got to sit there for a minute while the coating dissolves, then the medication dissolves in the bloodstream, it dissolves into the bloodstream and finally gets to where it goes. That's a relatively slow process, okay? If we take and we skip up one, or skip up to the top, right, where we give things intravenously at the paramedic level, I put it straight into your bloodstream, it takes effect pretty darn quickly, all right? So your route will have an effect on how your medication is absorbed. Yes, ma'am?
Would IV be intramuscular?
IV is not intramuscular, they are different. We'll talk about intramuscular here in just a minute. So, as EMTs, your common routes are sublingual, oral, inhalation, and intramuscular injection, okay? So as an EMT basic, under national curriculum, all right, some states have expanded scopes, but under national curriculum, these are the 4 routes that you use for your various medications, all right? So for sublingual, the medication is placed beneath the tongue, right, where it is dissolved and then absorbed. It's pretty highly vascular underneath and inside the mucosa of your mouth, all right, especially underneath your tongue. So we put that medicine in, the saliva dissolves it, the medication gets absorbed by all that nice vasculature that's right there just below the surface with a thin membrane on it, and it goes into the bloodstream and starts to work from there, okay? We can only use sublingual medications in alert patients, right? The ones that can follow commands, swallow, protect their own airway, because we're actually putting something into the mouth. We want to make sure that we don't create an airway compromise issue.
Would that include the nitro spray as well?
Yes, sir. So this would be used to administer the nitroglycerin tablets and spray. So of your drugs, all right, sublingual, the nitroglycerin is the one we give sublingual. Oral, this is where the drug is swallowed for absorption through the gastrointestinal tract, okay? Activated charcoal is one of those tricky ones because, yes, we put it in our mouth and we swallow it, but it is not, right, the charcoal is not absorbed into the gastrointestinal tract. What does it do? Binds and prevents things from absorbing, okay? So it is not an oral medication, all right? It is not absorbed. It is an oral medication, but it is not absorbed, all right? Let me back off and rephrase that, okay? It is an oral medication, but it is not absorbed, all right? Again, only in alert patients. Anytime we're putting anything into the mouth, they got to be alert, able to swallow, okay? And so for us, we're going to use it for aspirin, oral glucose, and activated charcoal, all right? So those are your oral drugs. Inhalation, okay? This is used for gases and aerosols. Medication is inhaled directly into the lungs for absorption in through the alveoli, okay? So if we think about how oxygen gets into the bloodstream, an inhaled medication does the same exact thing. Travels in the air as we inhale, gets into the alveoli, crosses the membrane into the bloodstream, and off it goes, okay? So these are used to administer oxygen, all right? And medications given by our metered dose inhaler or our small volume nebulizer, okay? So those are inhaled medication routes. The intramuscular injection, okay, this is where the drug is injected into a massive muscle for absorption, okay? When we do the epi-auto injector, the thigh is our spot of choice, all right? But there are other muscle masses throughout the body that if you have the training to do so, you can use. But for now, we'll just stick with the thigh for you guys, okay? This does require the use of a needle, all right? The auto injector has the needle inside it again. It's, spring-loaded, right? Shoots into the body and delivers the medicine, all right? Some discomfort to the patient, obviously, right? Anytime we place a needle in somebody's muscle mass, it's going to be a little bit uncomfortable for them, all right? And we use it to administer epinephrine via the auto injector, okay? So the only way you're able to do this type of injection is with an auto injector. Intramuscular into the muscle mass to be absorbed by the vasculature that feeds the muscle. IV, we're placing a catheter directly in the actual vein itself. Copy the difference? So we talked about routes. Now we talk about how the medications come, right? What is their form, okay? And the form of the medication, right, usually limits us to one specific route of administration, all right? So our common forms include, all right, a compressed powder or tablet, all right? So what administration route did we talk about that we think is going to be a powder or a tablet? Oral. And what medication do we say was oral? Aspirin mostly, right? Okay. Well, right now, powder or tablet. Okay. So powder or tablet is aspirin given orally because we don't have another way to get a tablet into the body. All right. Pretty self-explanatory there.
With the exception of nitroglycerin, because he puts tablets on his own, right?
Yes, I believe that is here in a different. All right. But yes, it can be oral. So liquid for injection. Which one of our drugs comes in liquid for injection? Epinephrine, right? Okay, so it comes in a liquid form. We inject it either via intramuscular or IV, something along those lines. Okay, which one comes in a gel form? Glucose. And how do we give glucose? On the tongue, in the mouth, swallow it, cheek, swish it around, right? Oral would be the technical answer for that one. Yes. A suspension. Albuterol. I heard charcoal. What do we think? Albuterol. Albuterol is going to be not going to be a gas. It's not going to be a suspension. Charcoal is our suspension, right? Because what a suspension is we have a solid form of a medication. So in this case, we started out with a fine charcoal powder, and we suspended it in a liquid. So we made a slurry out of it. So it is a suspension, okay? So it is a question that's going to ask you, and guess what it's going to have as one of the answers in addition to suspension? What do you think? It's going to say liquid, right? It's going to say charcoal comes in what form? It's going to put liquid and suspension. Which one is correct? Suspension, because the actual charcoal is a powder suspended in water. Does that make sense?
Just use regular tap water.
It comes. So in the tube, you'll have the liquid and the charcoal. You're just shaking it.
Okay.
Yeah. You don't have to mix it yourself. Good Lord, we'd never give it if we had to do that because it's such a mess. All right. It's all in the tube. Oftentimes you just got to kind of shake it and get it resuspended after it's settled. So. Yes, ma'am.
Are those single dose like the glucose?
Yes, typically. All right, so we talked about albuterol a minute ago, right? We thought it was a suspension. It is actually a fine powder for inhalation, okay? So inside that aerosolized little puff of air, all right, is actually a powder. That's why we got to shake the thing before we give it, that kind of thing. It's very microscopic, it's very small, but the albuterol is actually a powder, all right, that then gets aerosolized via air and inhaled, okay? Small volume nebulizer, all right, we've got the albuterol here, okay? So we actually nebulize the medication using either just straight air, or oftentimes we'll do it with 100% oxygen, and we're going to increase the oxygen levels and give the medicine at the same time for a double bonus, right? Gas, which one is this one? Oxygen, right? So oxygen comes in a gas form. So you can see where the forms tend to kind of dictate how our medicine is given, okay? Which is our spray? Nitroglycerin, right? So we had tablet form and spray form, okay? So there's two different forms there. Both can be given via the sublingual route, all right? So
you didn't even give us, I mean, for like a non-responsive patient, you didn't just like spray that little bit on the tongue?
Technically, no. If they're unresponsive, I'm probably not going to be wanting to give them nitroglycerin anyway, because it probably has something to do with their blood pressure if I'm thinking it's cardiac. So I'm not going to go dilating an already unresponsive cardiac patient. So the information that you need to know and understand, all right, in addition to the names, how they come, how they're given, okay, is going to be the indications, contraindications, dose, the route of administration, actions, and side effects, okay? And you get something here later on today for you to work on at home that's going to help you understand all of those, okay? So indications. Indications are the most common uses of the drug in treating a specific condition. They are geared toward relief of the signs and symptoms of specific conditions, okay, or the actual condition itself. All right. So, for instance, the indication for nitroglycerin is going to be what? Chest pain, right? That we believe to be cardiac in nature. We got a little caveat on there, but chest pain, we'll take it for now. Okay. So, nitroglycerin, we're giving it because somebody's having chest pain. Okay, and we're going to give it to try and alleviate the chest pain itself, which is a sign or a symptom, by alleviating the specific condition of decreased blood flow and oxygenation to the coronary arteries. Does that make sense? Okay. A contraindication, a situation in which the drug should not be administered because it will harm the patient. It's some sort of coexisting, either we're taking another medication, we're allergic to it, we've got something else going on in the body that when we put this other drug in, they're going to interact and they're going to cause problems. Okay? We talked about one very big one for nitroglycerin. What is it? Erectile dysfunction drugs, right? If you're taking erectile dysfunction drugs, that is a contraindication for administration of nitroglycerin. We get what a contraindication is? All right? So the dose, we need to know how much are we going to give. Some of them are just flat out, we give a certain dose. Some of them are weight-based, so we give so much per kilogram of the patient's body weight, right? But you got to know what it is that you're going to give, all right? So for instance, we've been on nitroglycerin here, so the dose for nitroglycerin is 0.4 milligrams per tablet. We give one tablet at a time, all right? So that is our dose for nitroglycerin, all right? Administration, the route by which the medication is given, okay? So you got to know the correct way to get the medication into the patient's body based off of its form, etc. All right, so nitroglycerin, what is our route of administration going to be? Sublingual, awesome. Okay, then we have the actions, okay? And the actions are the effect that the drug has on the body, all right? So, most specifically, the therapeutic effect, okay, is the intended positive response by the body. So that is what we want to happen, all right? So that is our therapeutic effect. I would have that definition written down somewhere, committed to memory, that kind of thing, all right? The mechanism of action is how the drug works to create this therapeutic effect. Does that make sense? All right? So the therapeutic effect is what we want to happen. The mechanism is how the drug makes it happen. Okay? So we're talking about nitroglycerin. What do you think our therapeutic effect, or what is our intended response in the body when we give nitroglycerin?
Lower blood pressure.
Relieve chest pain.
Relieve the pain. Right? Okay. What is this mechanism of action? How is it going to relieve the pain? By dilating the blood vessels and increasing blood supply to the heart, decreasing workload, etc., etc. Okay. The pain is the body telling you the heart is not getting enough oxygen, so we're going to, right, use the mechanism of action of vasodilation and increased blood flow to relieve the decreased oxygen supply, which then will give us our therapeutic effect of no more pain. Does that make sense? You guys follow that one? All right. Side effects, okay, these are actions that are not desired, right, and that occur in addition to the desired therapeutic effects. These may be predictable, they may be unpredictable, okay? So we've been on nitroglycerin this whole time, so we'll stay there, all right? We talked about one of the big side effects of nitroglycerin? Headache. What's the other one? Hypotension, right, or lowering of the blood pressure, all right? So these are things that we don't necessarily want to happen, okay, but are going to based off of what happens when we put the medicine in the body, okay? So headache, very predictable, all right? Hypotension, like I said, can be unpredictable. It's almost always there in some way, shape, or form. In some people, it's a couple of points here and there. Some people, it's like 50 points at one time on the blood pressure. You're like, whoa, what happened? You know, those are always the fun ones, okay? So they can be predictable or unpredictable. Some people, depending on the drugs, right? There's drugs out there that just work really well for people. Some don't work at all. Some people are very hypersensitive to them and they work way too well, all right? So some things are very unpredictable. But a side effect is something that we don't necessarily want to happen, but is going to happen because of what how the medication works in the body. Does that make sense? All right. So some key steps in administering medications, all right? So we need to first obtain an order from medical direction, okay? Every medication EMTs administer or assist with requires an order from medical direction, whether it be online or offline, okay? We need to make sure we verify any online order that's given to us by repeating it back to the individual that's giving it, okay? So if they say, we need you to administer 0.4 milligrams of nitroglycerin sublingual every 3 to 5 minutes, repeat to a max dose of 3. Then you need to repeat exactly what they said back to them so that you both know that you understood it correctly. Does that make sense? All right. You're going to want to select the proper medication, okay? Read the label carefully. And you guys, this drug box, there's not a whole lot of things that look alike, all right? Most of your drugs come in pretty, excuse me, in pretty identifiable, they're pretty individual, unique packaging, okay? So it's kind of difficult to get them mixed up. But as you go on, or you go anywhere else in the medical field, oftentimes, you'll get lots of different packaging. I work for a city government system. We do a low bid, right? So we buy drugs from whoever's got the lowest price that week when we ordered it. I have, we carry 4 vials of amiodarone in one of our bags. And there's been times when all 4 of them have had a completely 100% different packaging to them because of when they bought them, right? The size, the shape, the label, they're all different, right? And then all the different manufacturers don't talk to each other about what their labels look like. So oftentimes you'll get 2 different drugs that have the exact same label on them except for the name, all right? So you got to be very careful and pay very close attention to what it is you're giving, okay? Yes, ma'am.
Isn't there also like a liquid version of aspirin that I know that firefighters carry?
That I'm not aware of.
Look it up. I know there's a name that's long.
Well, look it up if you want, but I have no idea what it is. Do you know of a liquid version of aspirin?
We give a liquid ibuprofen.
Yeah, I mean, I know that like a Tylenol ibuprofen comes for like children, but not aware of. There's some like BC like headache powder that you drop in water. It's kind of like Alka-Seltzer type stuff, but I'm not aware of an actual liquid version. So
I'll let them.
if you find it, let me know. We'll talk about it. All right. So after we've got the proper medication, we've read the label carefully. All right. We're going to verify the patient's prescription. So when assisting with a patient's medication, we want to do our best to determine that, yes, indeed, this is prescribed to them, okay? This becomes a little difficult because that little teeny tiny vial of nitroglycerin or that albuterol inhaler, right? What do they normally come in when you get them from the pharmacy? A box. And where does the pharmacy stick the label? On the box. And what is the first thing you do when you get that medication? Throw it away. Take the thing out of the box and throw the box away. So oftentimes your inhalers, your nitroglycerin bottles, things like that, they're not going to be effectively labeled for your patient, okay? So you have to do a little bit of due diligence in the fact of just kind of ask them if your spidey sense is tingling, then it might not be yours. You can ask a few extra questions, right? But ultimately, if your patient says it's theirs, we're just going to take their word for it. We're going to document the fact that we asked that, is this yours? We verified. Right? And if it's not theirs and something happens, then it's on the patient. You asked, you documented. Got it? All right. So don't withhold anything. Don't, play 20 questions. Don't give them the Grand Spanish Inquisition, right? Just because you think it might not be theirs. If they say it's theirs, take your word for it. Document the fact that you asked. Move on and give them the medication. Okay? We always want to check the expiration date. If the drug is out of date, we do not use it, okay, under any circumstances. We check for any discolorations, impurities, all right? So all of our liquids that come in vials, right, they should be clear, all right? They shouldn't be yellow. They shouldn't have floaters in them, those kind of things. There's some specific, like, reconstituted ones that are a little different. But as a general rule, things should be clear. They shouldn't have floaters. They shouldn't be colored. They shouldn't be cloudy, okay? All those kind of things, all right? The packaging should be intact, lids should be on if there's a lids, those kind of things, all right? We're gonna then verify that we have the right form, route, and dose, okay? So we've got the right type of medication, we've got the right route for the form, and we have the right dose for the application that we're using, okay? Make sure that the label matches the order for the medical direction, okay? So make sure that whatever concentration of the medicine or whatever type of medicine, whatever route, whatever form you have matches the route, the dose that you're supposed to use. Make sure you can actually achieve that route and dose with what you have. If you don't, call the medical direction back, get the order changed so that you've got something you can work with. We're going to want to check the 5 rights. It was about the aspirin thing. We'll get to it at the end. Just hang on to it, okay? We're going to check the 5 rights of medication administration. I would absolutely commit those to memory, okay? We want to make sure we have the right patient, okay? Meaning if we're in a hospital setting, right, and we're supposed to give Mr. Smith the medication, let's make sure we've actually got Mr. Smith, okay? In the pre-hospital setting, right patient kind of applies to, does the patient meet our criteria, right? So the right patient for nitroglycerin is going to be somebody who's got chest pain, who we think is cardiac in nature, et cetera, all right? The right medication, we're supposed to be giving nitroglycerin, well, we better have nitroglycerin. That one's pretty simple, okay? The right route, meaning we know how we're going to give it, and we've got the medication that matches for the right route, okay, and matches our order. The right dose, okay, so we've got the right amount either drawn up, we've got the right amount, the right size pill, injection, all those kind of things, all right? And then the right time, meaning either if we're doing a repeat dose, we've waited the appropriate amount of time, or it's the right time, meaning it's time to give the medication, we don't have to wait for anything else, et cetera, all right? So those are our 5 rights. So we then kind of have a 6th right, if you will. They're starting to kind of add this into some of the curriculums, which is the right documentation, okay? So you then must document every medication that you give. And when you do, we want to know what drug you gave, what the dose was, how it was given, what time, and did it cause any changes, right? So if I give Kayla some nitroglycerin right now, I'm going to document that I gave Kayla 0.4 milligrams of nitroglycerin via sublingual route at 11:21 a.m. and her pain went from an 8 to a 6. Okay? So make sure you're documenting. Quick word on documentation, all right? Notice that I was saying 0.4 milligrams, right? Not just 0.4. When you're documenting and writing things down, make sure you're using that 0, okay? Because that indicates that there's probably a decimal point here. If I just do this, right, how easily is that little 0.4, how easy is that little decimal point missed, right? Maybe I just hit it real quick with my pen. It's there, right? But not very. You read it as 4 milligrams. How different is 4 milligrams than 0.4 milligrams? A lot. What's that? 10 times. You want to talk about hypoventilation and vasodilation, right? You're going to get a whole lot of it with 4 milligrams of nitroglycerin. All right? You can get a whole bunch of, you get tired of taking tabs by the time you're done, but this is very different, okay? So make sure that you are always documenting the full dosage, okay? You can use abbreviations if you want, all right? Sublingual, all right? But document every piece of the puzzle, okay? And don't leave off, if you've got a point, right? 0.3 is our dose for epi auto injector, so it's 0.3. Make sure you're using that 0, all right? It's got to have an amount, right? It's got to have one of the what's the word I'm looking for? Unit. Yes, that was the word I was looking for, right? It's got to have a unit, so milligrams, grams, milliequivalents, milliliters, all those kind of things, grams, all right? And then the drug itself, time, etc. Sound good? All right, for our reassessment, we must reassess our patient after we give medicine. So we want to know, all right, did anything change? Good, bad, indifferent? Did it stay the same? Did it get worse? Whatever. We got to document our changes. So the big things we're looking for is we want to make sure that we don't have any changes in our mental status. We want to monitor our airway, respirations, pulse, skin, and blood pressure, okay? So we're going to take another full set of vital signs and keep very close attention to our primary survey components, all right? For instance, we give somebody with chest pain nitroglycerin. Their mental status drops. They're now semi-conscious, right? We could have an airway issue. We're going to want to monitor the respirations. Chances are their pulse rate's going to be either up or down, depending on how badly we drop their blood pressure. Their skin's going to maybe turn a little cool and clammy, and now we're also going to have a decrease in blood pressure, right? So we're going to monitor our patient. This is where we're going to see some of our changes in our patient, okay? We're also going to see a change in SpO2, all right? Especially if we're using respiratory distress, right? We started out at like an 89, 90% with somebody in respiratory distress. We gave them some albuterol, and voila, we've got 95, 96. Did we make them better? May not made them better, but we at least improved our situation, right? So our SpO2 can give us some indications there, all right? We've got a change in complaints, relief of signs and symptoms, okay? We're looking for medication side effects, right? Both the ones that we anticipate and the ones that we don't, all right? I always tell people, hey, this nitroglycerin is going to give you a headache, all right? There's not a whole lot we're going to be able to do about it. It's kind of a given, but I do need to know about it so that we can document the fact that you got it, all right? So any side effects, make sure you're documenting. Whether you expect them to happen or not, just because we expect everybody to get a headache with nitroglycerin doesn't mean we forego documenting it, all right? Does that make sense? And then any other changes in patient's condition, all right? If you have any questions about any drugs, okay, there's some awesome places out there for you, okay? The AMA drug evaluation, there's the American Hospital Formulary, the PDR, or physician's desk reference. Any medication that comes always has some sort of package insert that gives you some more information. Poison control, those good people to call, right? You can have a pocket drug reference guide, all right? Quite a few people carry those around. Nowadays with smartphones, just about all of us have either the Hippocrates app is a pretty good one that's out there. Me personally, I just Google the drug name, right? And like drugs.com, or there's a few sites that tend to come up that are pretty reliable. So if you're ever out there and you have a question about a medication that you're giving, right, you should know those off the top of your head, but if for some reason you have a brain fart and you need to look something up, look it up, okay? Or if you're looking at your patient's medications going, oh man, this person's unresponsive, I have no idea what's going on, right? Just start looking up meds and you'll start to be able to build yourself a little bit of a picture about what might be going on, all right? Sound good? Using those up there. Like I said, there's an app for that. Hippocrates is one of the better ones. I just don't feel like paying for Hippocrates, and to me, it's just as easy to Google it. All right. Questions, comments, or concerns about